So moving into this low back pain case scenario. So starting with the subjective information, so we have a 50-year-old with diffuse bilateral low back pain, desk worker, and this pain was of a gradual onset after beginning a couch to 5K. Okay, so when any client tells me that the pain came on as they increased the external load acting on their body, meaning they're engaging with activity an awful lot more and putting more force demand on their body, particularly when it's running and particularly when they've been a desk worker, I'm putting an awful lot more focus on or more consideration on how well the lower limbs are able to handle and dampen those forces acting from the ground up to give that spine the opportunity to stay variable and not guard and stiffen. Okay. Now you could equally say, well, this person's a desk worker. They're probably not building much contraction tolerance locally around the abdominals, around the lumbar extensors, so on and so forth. But I'll generally put a lot more emphasis on the lower limbs initially to build that contraction tolerance and capacity before I do it on the lumbar spine, unless there's been a clear surgery, trauma, long period of guarding through the lumbar spine. Okay. Now, briefly looking at this individual's toe touch here. Okay, this is a representation of their toe touch. What do you see differently here compared to this one here? We can see that there is much less spinal flexion and an awful lot more. So this is your pelvis here, and an awful lot more hip flexion, range of motion. So the angle between that femur and the pelvis is much more closed in the front. So this individual is really concentrating that toe touch via hip flexion. And to get those fingers touching their toes, do you think we'd need more hip flexion? Or do you think we'd need more spinal flexion to allow for the posterior part of the spine to open and allow for the lumbar extensors to lengthen and spinal extensors as a whole to lengthen to allow the hands to get closer to the ground? We need more spinal flexion in that scenario, okay? So that, again, from a sagittal plane focus perspective, that will be where I'll direct an awful lot of my focus here. Okay, so going through the objective findings here, what was limited and painful? Lumbar flexion range of motion was limited and painful. So when we try to kind of deconstruct this person's movement and try to see, could that lumbar spine actually flex? They struggled and it was painful. Okay, that will influence again what you might do during the early stages of rehab then. Spinal rotation was limited and painful, but lateral flexion range of motion was limited and non-painful. Okay, so maybe from a range of motion perspective, we might need to focus on lateral flexion first. Okay, because initially I might we've got a local range of motion strategy here for lumbar flexion, more of a local strategy for spinal rotation. But here we have a strategy to try and get some lateral flexion, and we can actually get a little bit of spinal flexion here as well. Okay, but we'll talk about that in just a moment. We also have weakness and pain when loading the lumbar flexors and the extensors. The glutes, hamstrings, and quads were weak and non-painful. So again, weakness across the main kind of hip and thigh muscular tissues. Again, probably weakness in the calves as well. Are they really important? Yes, for a runner, but for the issues we're dealing with around the lumbar spine, again, I'm going to put more emphasis on those thigh muscles, hip muscles initially. Okay, so we have weakness and pain through lumbar flexors and extensors. Okay, now you could hypothesize that maybe, there's pain with the lumbar contraction of the lumbar flexors because we can't get into lumbar flexion, or maybe there's just too much sensitivity around the lumbar spine to really tolerate contraction through the lumbar spine. Okay, so maybe that's off the table until we get range of motion back, until we get some space back in the spine. Okay, we can certainly try to find a tolerable entry point for contraction, but again, when you're working with real clients in the real world, you don't want to throw too many variables into the mix early on. Lumbar flexion and spinal rotation were limited and painful. So again, we can try these local strategies here, but they might not be tolerated well. Enter your coordinated strategies. This is where, again, we can start to couple this limitation and lumbar flexion with some load through the glutes, hamstrings, and quads, because then we're simultaneously working to gradually expand some lumbar flexion within tolerance, but also simultaneously showing the system that we can start to shift that stress and load and force into the lower limb, giving that nervous system the experience that, hey, I can actually get some load into those tissues. Maybe I don't have to guard as much through the lumbar spine. And that can help to increase the tolerance to lumbar flexion and actually increase the range of motion. You'll be surprised someone has a really locked up lumbar spine, really guarded lumbar extensors. You get a very small amount of flexion within tolerance, and then you send that load into the quads, into the glutes, into the hamstrings, and all of a sudden you feel the lumbar extensors begin to relax. And then that opens up the opportunity for you to then do more local work there. Okay, could you do some manual work? Absolutely. You could do some manual work. I always try to use more active movement strategies whenever I can, and then use manual strategies, passive strategies, as a way to help me facilitate active movement. I don't do manual passive work first, because I'm using the manual passive work to get to active movement. So I want to first see how the individual handles active movement. Okay, for me, when you start with manual, it makes it very, very messy. Okay, because again, you don't know what you're actually working towards. It disrupts the pathway of rehab, in my opinion. So we can begin. So initial goals here: increase lateral flexion, range of motion. But we could also say, let's increase lumbar flexion, range of motion here as well, but coordinatively. And then we can increase glute, quad, and hamstring strength too. So down here, we could use these two coordinative range of motion strategies to help improve lumbar flexion, range of motion. We have to be clear on the muscular tissues that we're challenging within a coordinated range of motion strategy. So this would be a glute and quad bias, and this would be a hamstring bias. We just have to be, of course, with this strategy here that we've spoken about in the previous videos, we want to be very mindful as to how much flexion the person can tolerate. It might just be a very small amount of flexion they can handle, and then we get that load into the lower limbs and then gradually push from there. Oftentimes, and this is what a lot of my initial sessions might look like with these situations, is working on the quads and glutes to facilitate lumbar flexion, working on the hamstrings, again, to work on that posterior tilt. Again, if they're very weak, I can use the hands to press in for the clients to assist, but we're working on that lengthening of the lumbar extensors by peeling and scooping the hips up off the ground to engage the hamstrings. And I really like to use this strategy here when trying to, again, maybe bias lumbar flexion on one side, or to just get some lengthening through the lateral flexors, through the obliques, through your QL muscle. So what you're seeing here is a modified tall kneeling position. We'll go through this in much more detail in the rehab module. But what I'm doing here is I'm in a tall kneeling position. I'm having the clients rest their hands on a bench in front. I'm getting them to get a little bit of a posterior tilt, shift back, and then use their hands to drive laterally to shift the pelvis and even through the lower rib cage to open up this side here. And what they'll often feel here is, as they're passively moving with the hand, they'll feel a significant length through the lateral lumbar spine here. And then we can breathe into the rib cage, breathe into the lumbar spine to really expand those tissues further. And we can do that in both directions. And again, you're really challenging the erectors, the QL, the obliques on one side, but you can do it on both sides. And that can often be more tolerable for clients. And then you can come back and work on more sagittal plane dominant strategies. But this is one that I'll use quite a lot. And like I said, we'll go through that in much more detail in the rehab module. And that may be how rehab begins and progresses. We'll start with more lateral flexion range of motion strategies. Couple that with some coordinative range of motion strategies for lumbar flexion. Okay, so when you're using a coordinative range of motion strategy, first, be clear on what range of motion am I trying to target, and then be clear on what muscular tissues am I loading simultaneously. So is it the quads, is it the glutes, or is it the hamstrings? Okay, there's other ways you can do this as well, but these three options here would be the ones that I would use initially. I might even use these at the very beginning to send that load into the lower limbs, and then work into this lateral flexion range of motion strategy, where I build some tolerance initially, and then on the next session, I'll retest to see what lumbar flexion is like, spinal rotation is like, and then if more tolerable, we might start to gradually expand those as well. Okay, so again, it really comes down to what you've gathered from the objective assessment, the subjective assessment, the movement options map that you have created, the goals you have set in place, the goals that you have established, and then it's the process you need to go through to achieve those goals. Okay, most people think, oh, you've got limited lumbar flexion, here is the exercise you need to increase that. It's not that simple. People that say that don't work with real clients day in, day out, because ultimately it's down to the process you work through to get there. That's why we might have to start with these coordinated range of motion strategies. We might have to start with more non-painful strategies that are still limited, and then we can start to push into these more local range of motion strategies if necessary as well. And then there are other things we might have to get through in the middle and later phases of the rehab process as well. Okay, so if there's one thing you'll hopefully take away from module 1, it's about the process that you move through. So as you're moving through a process, you have to have these concepts, these frameworks in your mind to guide you through that process. Because along that process, there will be lots of tweaks, lots of adjustments, modifications you'll need to make. And ultimately you can only tweak things appropriately if you know why you're doing what you're doing and what you're working towards. And having all the body tweaks and task tweaks that we went through earlier on in this module available to you will give you many options to tweak and adjust things to keep the client moving towards their goals.